So to begin, maybe each of you could give an opening statement of just your just general thoughts about your intentions for this panel and why you are here, and in general why you do speak in public, what in general it is you're here to communicate about. Just maybe each of you could just take 5 minutes to give us a little opening.
So I have worked with thousands of people who have struggled with depression their whole life, and they have tried everything. They've tried medication, they've tried various forms of therapy. They've come to me and say, oh yeah, well my parents were depressed, so this is just inherited, and I guess I'm going to have to live with it. And it's not true. I have seen over and over again people who learn to love themselves. So much of depression comes from abandoning oneself, and I'll be getting into that a little bit more. But if you had like an actual child and you're ignoring the child, you're judging the child, putting the child down, turning away when the child is upset, that child will likely get depressed. And that's what happens on the inner level. We abandon ourselves, and so of course we get depressed. And I'll never forget, one of my 5-day intensives, there were 4 women there who I didn't know were on antidepressants. One of them had been on for 20 years. Can't believe it. And at the last day, unbeknownst to each of them, all 4 of them, now I don't recommend this. I think when you go off, especially after you've been on a long time, you go off with a doctor. But all 4 of them said, I went off my antidepressants at the beginning of the intensive. I've had no side effects from going off of them, and I feel better than I've felt in years. I'm not going back on them because I now know why I was so depressed. I'm never going to be depressed again. And one of our facilitators, who now teaches inner bonding, she came to her first intensive very depressed. She was a therapist. She'd been through therapy school. She'd been through everything. And she was depressed. And within the first half hour of work, she said to me, oh my God, now I know why I've been depressed. I'm never going to be depressed again. And that's been true. That was 10 years ago. She's never been depressed again. So I know that inner bonding works miracles with depression.
I was a professor of psychology, clinical psychology at the University of Connecticut, and at the time I had a private practice, and I was seeing clients, and some of them were very depressed. And back in those days, I had no reason to doubt the efficacy of antidepressants. I mean, everybody knew they worked, right? And I knew they worked. And so if I had a client who was very depressed, severely depressed, I had colleagues who were psychiatrists. I'm a psychologist, so I couldn't prescribe, but I had colleagues, and I'd refer the client to a psychiatric colleague to get an antidepressant and continue to do psychotherapy work, but that would hopefully take the edge off. And sometimes, not always, but sometimes the client would come back and they seemed to have been helped, and I assumed, okay, that's what everyone says, that's the antidepressant working, and that was a good thing to do. Until I started to do research and started looking at the drug trials. First at the published drug trials, and then I went to the FDA, and I used the Freedom of Information Act, and I got the data that hadn't been published, data produced by the drug companies, sent to the FDA, but never published. And indeed, I found out, in these clinical trials, people getting antidepressants, many of them improved. And some of them improved quite a lot. But what surprised me was people also improved if they had been given placebo. These are placebo-controlled trials. And many of them improved a lot. And sometimes the improvement was lasting. And the difference between improvement on the drug and improvement on the placebo was minimal. Well, I have since done, I think, about 4 of these meta-analyses on the FDA data, on published data, on combinations of the FDA data and published data. Others, when I started reporting this, have said, oh, you can't be right, you must be wrong. And they've done their own meta-analysis, and you know what? Everybody gets the same results and the same outcome. The effects of antidepressants, the beneficial effects, are almost entirely, if not entirely, a placebo effect. But they are potent drugs that can have many, many harmful effects, side effects, health risks, and addiction for about a third of people who get on them. And so I wrote a book. I've been speaking all over the world. I continue to. And some people just hate me. But that's okay.
Well,
I'm doing what I think needs to be done.
I love you.
Thank you.
I'm a fan of Irving because I read his book when it came out, and I have told so many of my clients who say, oh, my doctor says get on antidepressants. I said, you've got to read this book first. And then they never go on them. And so I'm so thrilled with that book.
So right now, there are people in the audience, there are people watching online, there are going to be watching this on replay, and they're already furious. They're saying, what is the world are these people talking about? I have a chemical imbalance, I'm manic depressed, how dare you even suggest that I have anything to do with this, and it's the meds are saving me, so these people are crazy, I am manic depressed, or I have a chemical imbalance, I was told that, and the only answer is medication, and what are you guys saying? So, okay, so for those people that have been told they have a chemical imbalance, told they have manic depression, and told they need to be on pharmaceutical drugs, how do you respond when people?
Why don't you start with that? Because
Okay.
the chemical imbalance thing is...
And I'm going to talk about depression rather than manic depression. And the only reason I'm going to do that is I know the data on depression inside and out. I've studied the clinical trials. I haven't looked at that closely at the literature on the bipolar disorder, as it's called,
Yeah, I'll
manic
talk about
depression.
that a little bit.
So one of the things I've learned is I have to be very careful. I come under a lot of attack. So I won't say anything unless I know I can back it up. And yes, people do, and this is the tricky part, because people go in, they're told they have a chemical imbalance. Now, there's not a reputable scientist that I know of today that studies brain chemistry and depression who still believes in the chemical imbalance theory. It has been refuted. It's as close to any theory in science to have been disproven. One of the ways we know that, take a person who's not depressed, and it's possible to very quickly delete the levels of serotonin in their brain. The basic idea, the most popular chemical imbalance theory, is that depression is caused by not having enough of this neurotransmitter, serotonin, in the brain, in the synapses in the brain. Now, it's very easy to give people a beverage that has all of the precursors for all of the neurotransmitters except serotonin, and their serotonin levels drop. And if depression were caused by not having enough serotonin, that ought to make them depressed, but it doesn't. So we know that depression is not caused by not having enough serotonin.
So I've worked with quite a few clients with manic depression, schizophrenia even, and when they follow the kind of diet that heals their gut, because I'm sure most of you know by now that 80% of the immune system is in the gut, and that the gut creates toxicity in the brain when it's out of balance. And of course, there's so much in our environment that creates an out of balance gut. And so when my clients are willing to eat really well and do the work they need to do to heal their gut, plus to do the inner work they need to do to learn to love themselves rather than reject and abandon themselves, they heal from bipolar disorder, and they're able to get off their lithium, their medication. I've seen it over and over again. And with schizophrenia as well. We're not talking about that, but I've had clients who, the same thing, were diagnosed for 20 years and on medication, changed their diet, learned inner bonding, and they're no longer schizophrenic. So, so many of these disorders are being caused by things other than this mythical brain imbalance.
I appreciate what both of you are saying, but to the best of my knowledge, I believe that right now, if maybe we're talking about adults, but if someone's under 18 and they're depressed, it seems like the standard policy is to bring them to someone who tells them that they need to go on an antidepressant. So what about with people under 18? Do those people need to go on an antidepressant, or are you still saying for them there should be a different course of action?
So many of them are depressed because of their diets. They're drinking sodas, they're eating candy, they're eating donuts, their guts are decimated. They have leaky gut syndrome, and that's creating the toxicity in their brains that's creating the depression. And over again, you see that when parents change their diets and the children change their diets, their depression goes away, along with learning how to take loving care of themselves.
And I have to tell you, looking at the data, that the clinical trial data on the use of antidepressants for children is even worse than the data for adults. They don't show this small difference between the real drug and the placebo. They don't show any difference at all, but there are risks, and one of the risks for young people, for children, for adolescents, and young adults of being on an antidepressant is that it increases the risk of suicidal behavior. The FDA recognizes that, and a number of years ago, they issued a black box warning people about that, that's on the label for SSRIs, for the most popular antidepressants. So I think the worst thing you can do is to get a child started on these medications.
Margaret, you've worked with, at this point, thousands of people. They come to see you in groups, they speak to you personally, you do this every day, and the constant theme is people are depressed, they're anxious, they're angry, they're sad, they're lonely. Irving, you've done a tremendous amount of research on this. Could you, instead of just telling your conclusion, explain what the basis is of your conclusion? How many people have you seen that have depressed that you've actually seen turn it around? What studies have you seen that, maybe go into a little more detail of why you came to these conclusions, as opposed to, tell a little bit of what made you come to this conclusion and how big the data set is that you're basing this on.
Yeah, well, as I said, a lot of people come to me depressed. Very few leave their work. I can't think of anybody that's left their work with me with depression. That doesn't mean that they don't get sad sometimes. We all do, and difficult things happen in our lives. But the real cause of emotional depression, other than physical, is that most people have learned to reject themselves in many, many ways. And I started to talk about this before. We reject ourselves by staying up in our head. When we were young and we didn't get the love we needed, there were huge, huge painful feelings, loneliness, heartbreak, helplessness over our parents and others and peers and bullies. And we couldn't manage these feelings, and most of our parents had no idea how to manage their feelings. If you think about your parents, what did they do when they were upset? Did they sit down and think, I wonder what I'm telling myself and how I'm treating myself that's causing me to feel bad? Or did they turn to alcohol or drugs or TV or some other addiction? Did they yell at each other and scream at each other because they were upset? Very few of them knew how to take responsibility for their own feelings, and so their children did not learn how to take responsibility for their feelings. So when they come to me, they have no idea that they are likely causing their own depression because they don't know how to manage their feelings. And so as they learn to move into their heart, as they learn to give up getting out of their head, get into their body, as they learn to tune into these judgments, these harsh judgments that they level at themselves, as they learn to stop turning to various addictions and instead turn inward towards their own feelings and learn from them rather than avoid them, as they learn to stop making everybody around them responsible for their feelings, as they learn to tune into a spiritual source of love and wisdom that they can bring inside and down inside to those feelings, and they're open to learning rather than protecting against all of their pain, because all of our feelings are informational. All of our feelings are informing us about how we're treating ourselves, whether we're abandoning ourselves or loving ourselves, or what's happening in relationship to others. And so if we depress them with medication or with being in our head or judging ourselves or turning to addictions or making others responsible, of course we're going to be depressed. Why wouldn't we? And so when people learn to lovingly learn from and manage all of their feelings, when they learn to embrace their feelings rather than avoid them, instead of getting deeper into depression, they move out of depression, and they move out rapidly. It happens very quickly, sometimes in a day or two, sometimes, like with my client, in a half an hour. When they really get what they're doing, they move out of it. And so for 46 years, I've been doing this, and I've seen this with thousands and thousands of people who were convinced that it was hereditary, it was brain balancing, and it wasn't. It wasn't at all. It was how they were eating and how they were treating themselves.
You had asked Steve about how many patients, how many clinical trials we had looked at and that my conclusions are based on. And what I'll answer that with is not just the clinical trials that my colleagues and I examined back in 2002 and 2008, excuse me, but the most recent data on it, which have not yet been published even, but it comes straight from the FDA. And this is an analysis by a senior analyst at the FDA of 92 clinical trials with more than 23,000 patients. And the drug placebo difference is exactly the same small drug placebo difference that we reported in 2002. So I'm absolutely certain that these data are reliable. Now I want to mention two additional things. First of all, a warning. If you are currently on an antidepressant, do not just stop taking it. Do not just stop taking it. There are a number of reasons for that, and one of the reasons for that is the problem of withdrawal symptoms, antidepressant withdrawal syndrome. So there can be consequences if you are unhappy taking them, if you're not getting enough benefit, if you're troubled by the side effects and the health risks. Get some help in getting off of them. Don't just stop by yourself. That's the first thing. The second thing, and this also is data-based and looking at hundreds of clinical studies and meta-analyses. Meta-analysis is just a fancy word for putting the data together from a whole bunch of studies and seeing what they tell you when they put them together. One of the things we know is that there are all kinds of alternatives. There are many, many treatment modalities that work at least as well as antidepressant medication. And that includes psychotherapy and various forms of psychotherapy, and it includes physical exercise, and it includes acupuncture, and it includes mindfulness meditation. There are many alternatives that work at least as well and don't have the risks and side effects that are associated with these active drugs. Especially if you've never been on an antidepressant. If you have a loved one that's depressed and has never been on an antidepressant. if it's to be used at all, it would be the last resort after you've tried everything else.
Well, and to just use it temporarily, not for 20 years.
Yeah, I would try to avoid using it temporarily, and I'll tell you why. There are data indicating that using an antidepressant for as short a time as 4 to 8 weeks can increase the risk of relapse and getting depressed again if you do get better, compared to getting better by almost any other means. So avoid them, especially as a first approach, if you don't want to wind up just being addicted to them.
You know, depression, like any other feeling, has information. So instead of avoiding it with medication or avoiding it with addictions, turn towards it, embrace it, welcome it. Ask the depression what it's trying to tell you. That's what we teach. We go inside, okay, I'm feeling depressed. We'll go inside with an intention to learn. In the inner bonding process, there's only 2 intentions. One is the intention to protect against our pain with some form of controlling behavior, and the other is the intention to learn about loving ourselves and sharing love with others. And so if we move into a true intention to learn about loving ourselves, and we ask inside, we ask that depression, is there something I'm doing, some way I'm treating you, something I'm telling you that's causing you to feel this way? You might be amazed at what your inner self says to you. Try it if you're depressed and see what your inner self says to you.
We are speaking about antidepressants. When I hear other terms like ADHD, attention deficit hyperactivity disorder, and parents are told that they want their kids, the schools say that the kids should be on it, does that have anything to do with this discussion, or is that a totally separate issue?
I think it has everything to do with it because, once again, it's been shown over and over with studies that when children are fed well, then their ADD, ADHD heals, but also it has to do with an environment. You know, what happens with the people that I work with is that when they're in a very loving and safe and accepting environment, they also heal. I once had a young man come to an intensive who was suffering from bipolar disorder, and he had had a really hard time. He was on a lot of medication. But within the 5 days of the intensive, all his symptoms went away because he felt so loved and so safe and so secure for the first time in his life. Now, that's not easy to find, unfortunately. So, you know, he had to go back into the world that wasn't so loving and wasn't so accepting. But that's part of it with like ADD, ADHD is helping the parents understand what they're doing, how they're treating the children, and how they're feeding their children.
And I'm going to pass on that again only because I'm going to stick to the data that I have analyzed and that I know inside out. And I've read books, and I've read books that I find very credible that take very similar approaches to ADHD and bipolar disorder and schizophrenia, but I am not going to make any claims about that. I can talk to you about depression and anxiety disorders and the efficacy or lack thereof of antidepressants for those disorders. And so that's what I'm going to stick to.
And is there a difference whether we're talking about short-term depression, a few weeks or months, versus someone who stays on the drug for 6, 8, 10 years? Is there, does it work better for long-term? If you stay on it, is there a difference in your findings, short versus long-term?
Here's what happens. If you get better on an antidepressant and you go off it, you're very likely to relapse. Relapse rates over the long term on antidepressants are about 50% when people get off of them. So they wind up being hooked onto them. Sometimes they relapse and get depressed anyway. Relapse rates with psychotherapy and even with placebo treatment are half that amount. There was this lovely study that was done in which people depressed people were put into 3 different groups. They were randomized. They were assigned to one of 3 different groups. One group was given an SSRI, an antidepressant. Another group was given a physical exercise program. And the third group was given the combination of the 2. Maybe the 2 will work better than either one alone. And there was a nice response to each of the 3 regimens, same size response. And then they looked 10 months later. People got better. How many of them relapsed? And what they found was high relapse rate of those who had been on the SSRIs, even though they could continue to take them. Very low relapse rate. It was about 40% relapse on the SSRI. Relapse on the exercise program was 8%. Very, very low. And what about when you combine the 2? Adding the SSRI to the antidepressant increased the relapse rate back up to the 40%. Adding the antidepressant to the exercise program quadrupled the risk of relapse and becoming depressed again.
Margaret, you work with some people that had very serious trauma in their life, terrible sexual abuse and being involved in wars and violence and terrible things, and you've worked with lots of them over the years. What percentage of these people do you feel the inner bonding, the inner work is not enough, and you feel that they really need pharmaceutical drugs or antidepressants?
Frankly, I don't think any of them ever do need pharmaceutical drugs. I never recommend that, ever. I just refer them to Irving's book. People who have been through a lot of trauma, they need a lot of help. And inner bonding is one of the forms of help. It's not the only form of help. I also recommend that they get trauma therapy. There's many forms of trauma therapy now that are very, very helpful to people. The emotional freedom technique, the revolutionary trauma release exercises, somatic experiencing, EMDR, there's many of them that help to release trauma out of the body. And these work very, very well in combination with inner bonding. One of the things that happens as people practice inner bonding, it's about developing what we call a loving adult self. And when you learn to be a loving adult, and when you're focused on what is truly loving to yourself, then you're going to be very motivated to take loving action, which means you're going to get adequate exercise, you're going to get adequate sleep, you're going to take care of your finances, you're going to eat well, you're going to take care of yourself in relationship to other people, you're going to get your life organized, and you're going to develop your spiritual connection. A loving adult attends to all of those forms of personal responsibility. And when you actually do that, you get better, regardless of the trauma that you've been in. I mean, what Stephen said is accurate. I've worked with people with the most severe trauma that you can ever imagine, and they heal without medication.
Irving, if you are confident after you wrote the book, it's been years since then, and you've had more studies that support this, and if your studies showed that the chemical ingredients in the drug were not responsible for the improvement from depression, has your research become widely accepted and the standard throughout the country?
My research is very controversial internationally. It's had an impact. It's having an impact. It had an impact in the United Kingdom, where they changed, not just on the basis of my research, but on the basis of other people's research, finding the same kinds of things that we have found, and they changed their treatment guidelines for depression. One of the things they decided is that more emphasis should be put on psychotherapy. And one of the things they've done to make that possible is undertake a program. The British government, this is something that united the Tories And the Labor Party, they don't get united very much. They all approved this together. They undertook a program to train 10,000 new psychotherapists to provide free psychotherapy to depressed people through the National Health Service in the United Kingdom. They did that because of evidence that it cut the rate of relapse compared to putting people on antidepressants, and that in the long run, it's actually cheaper. It's actually cheaper because psychotherapy comes to an end and you don't need it anymore. And you go about your life and you're not incurring treatment expenses. Whereas with the medications, you wind up having to stay on them to avoid relapse. And actually the data, there was a cost-benefit analysis done in the United States. There was a cost-benefit analysis done in the United Kingdom, and they came to the same conclusion. While the initial cost of psychotherapy is greater than just giving somebody a pill, at 9 months, you break even. And from that point on, it's cheaper to have been on the psychotherapy than to be maintained on antidepressant medication, and safer, and in the long term, more effective. Short term, no real difference. Long term, more effective.
You know, I'd like to share something that, you mentioned the SelfQuest program that I worked on for so many years, and a woman wrote to me who had bought the program, who I'd never met, and she said to me, after doing SelfQuest, I got off my antidepressant medication, I lost 110 pounds, and I went back to school and got my degree, and my whole family, my kids, my relationship, everything is improving. That's where my heart is, that people can actually do it on their own. They can learn this on their own, that they don't have to spend tons of money. Another woman wrote to me, and she said, and I had also never met her, and she said, I've been on heroin for, this isn't depression, but probably she was depressed, and she used heroin instead, medication, and she said, and I've been to every treatment center in the country, and I haven't been able to get off until I went through SelfQuest. She says, now I finally see why I was on heroin, why I was so miserable, and what I need to do, and I've been clean for the last year, when she wrote me. And she's kept in correspondence with me. Her whole life changed. So it's possible for people to learn to do this without being tied into medication their whole lives. It's possible for people to learn how to heal themselves. And that is what I teach people to do, how to heal yourself and to be free of that and to be dealing with yourself in a way that brings inner peace and joy rather than depression and misery.
Can I follow up on my answer to your question, Steve? Change in medicine is often very slow. It takes time. There was a surgical procedure they used to do for angina back in the 1950s called mammary ligation. Seemed to work. 80% of people got better. They did 2 trials with sham surgery as a control. You know what sham surgery is? Placebo surgery. They open the patient up and they sew the patient back together again, and they don't do the mammary ligation. And it had the same success rate. They don't do it anymore. There's a surgical procedure called arthroscopic surgery for osteoarthritis of the knee. That was studied with a sham control as well. And when they cut the patient open, they didn't do the surgical procedure, but then they sewed the knee back up again. For the first year, the people in the placebo surgery group actually did better than the people in the real surgery group. And at 2 years, there was no difference between the two. But they still haven't stopped doing it.
Well, it's a moneymaker.
It's not just that it's a moneymaker, you have to have an alternative. There is an alternative here, and it used to be, when I started practicing, psychiatrists, like psychologists, used to do psychotherapy. And some of them still do, and some still do. But most psychiatrists have gotten out of the psychotherapy business. So what do they have? They have the pills. And there's an old saying, if what you have is a hammer, everything looks like a nail.
Yeah, and I think what you said is so important. They don't know what the alternatives are. They don't know what to offer. And I see this over and over again with medical doctors who are not tuned in to what's really going on. They don't know what to do.
But it will change.
Yeah.
It will change. My prediction is 50 years from now, people are going to look back at the antidepressant era and look at antidepressant medication the way we now look at bloodletting.
There are people who have said, I was very depressed, I went on antidepressants, I was on them for a long time, and I got better. And you said in your book that the placebo does almost as well, and that if the placebo has side effects, like if a drug has side effects, it does even better. Do you want to explain that?
Sure. So if you have these clinical trials, you get this small difference. It's not clinically meaningful, but it is statistically significant. It's small, but it's statistically significant in about half the trials. In half the trials, it's not even that. I have to tell you, because I'm using clinical significance, statistical significance, let me just explain what I mean very briefly. Like that, if someone tells you it's statistically significant, all it means is that it wasn't just a random chance finding. It was a real finding, but it doesn't tell you how large it is. So let's say someone has done a study on 500,000 people and has found that smiling increases life expectancy by 10 seconds. With 500,000 subjects, I can virtually guarantee you that 10-second difference is going to be statistically significant. It's just not meaningful, right? So the question is, why is there even this small, statistically significant, even if not clinically meaningful difference between the outcome on antidepressant and the outcome on placebo? And I can answer that for you and tell you why. Imagine that you have been recruited for a clinical trial of an antidepressant. Before you start, you have to give informed consent, and that means they have to inform you. And the first thing they tell you is, now, this is a clinical trial, and so some people are going to get the real drug and some people are going to get placebo. And it's double blind, so we don't know who's going to get the drug and who's going to get the placebo until the end of the trial. What you need to know is that the drug has some side effects. It can cause dry mouth, insomnia, agitation, sexual dysfunction, a number of signs. They list the side effects. They actually list them. They have to do that. And so the patient says, okay, they sign the understand the potential risks, side effects, and they're given a pill. Now imagine you're one of these patients. You know, if I was in that situation, I'd be wondering, which pill is this? Is this the real pill or is this the placebo? I don't know. It's double blind. They said they're not going to tell me until the end of the trial. Gee, my mouth's getting dry. My mouth is dry. That means I've been given the real drug. Hooray! I feel better already. So what you get when you're in a clinical trial, when they ask patients on clinical trials whether they think they've been given the drug or the placebo, if they're in the placebo group, they'll give you a 50-50 chance. Half of them will tell you they've been given the drug, half will tell you they've been given the placebo. If they've been given the real drug, almost 9 out of 10 of them will tell you, and this is from research, it's not just my opinion, 9 out of 10 of them will tell you, oh, I'm in the real drug group. It's not double blind, they know, and the treating physicians know it. So the real comparison that you're getting in these placebo-controlled trials of antidepressants is the difference between a placebo and an extra strength placebo. A placebo where you know you're getting the real drug instead of, well, maybe I don't know what I'm getting. And that increases the benefit. Just knowing that you're getting a real treatment makes the treatment more powerful than thinking you might be getting a real treatment and you might be getting placebo.
Now, didn't I read in your book that some of the trials, they actually have a placebo with side effects?
There have been 9 trials. This is called an active placebo. Thank you, Margaret. It's called an active placebo. It's to try and disguise this, the breaking, prevent the breaking of blind. And so what they do is they give some kind of real drug that no one has any reason to believe should have any effect on depression at all, but produces side effect. And what they've done is they've used atropine, which causes dry mouth. And there have been exactly 9 clinical trials with atropine as an active placebo. 2 of them showed a difference, but also showed breaking of blind despite 2 out of 9, as opposed to, if you look at the published literature, 75% of the clinical trials with an inert placebo show a statistically significant difference. You add side effects to disguise whether you're on the active drug, to get people on the placebo to think they're on the active drug, and you cut that difference to almost nothing.
I don't feel bad that I have gray hair, but if you told me that the reason that people have gray hair is because they're very angry people, I might get defensive. So when you tell people that, they feel depressed because they have a chemical imbalance, they feel like, hey, it's nothing I could do. Are people going to feel blamed and judged like you're saying that the reason you're depressed is you're doing something wrong, where they were feeling like there was nothing they could do, it was out of their control, and now we're saying it is something that has to do with your thoughts and the way you're treating yourself, and are they going to now blame and judge themselves?
I think it's just the opposite. I think when you tell people you've got a chemical imbalance, you've got a physical disorder, you're a sick person, there's something wrong with your brain, when in fact, depression can be a normal response to a terrible situation. And I'll tell you the most egregious example of that in terms of changes in diagnostic criteria. It used to be that if someone suffered a tremendous loss, the loss of a loved one, that was an exclusion criteria. They wouldn't be diagnosed as mentally ill because there was this reason for their depression. They have changed that. They've dropped the exclusion criteria, and here's what happens. Imagine you're a parent and you've lost a child. I can't think of anything worse to imagine. You are going to feel depressed. You will have symptoms of severe depression. Of course you will. If you don't, there's something wrong with you. With the current diagnostic system, you've got 2 weeks. If you're not out of that depression, if you still would qualify for a major depression diagnosis 2 weeks after you've lost a child, now you're suffering from major depression. You're mentally ill. And I would say 2 weeks. What's 2 years? Oh, yeah, maybe it's a lifetime in terms of some residual sadness and sense of loss. That's really something to cope with.
It depends on the depth of the love.
Yes, the greater the depth of the love, the greater the sense of loss, right? Absolutely. So one of the things that I've told friends and loved ones is just that. And it's worth it, isn't it? To have to suffer the loss, because if you've had that, to have that love, would you have given it up? But you're going to feel depressed with a major loss, and it's normal. And it's normal. And the last thing I would do is put someone on an antidepressant, and what I know happens is they don't even wait the 2 weeks. Antidepressants are doled out like candy to people who are not depressed. I've seen antidepressants prescribed for lumbar back spasms, for insomnia. Insomnia is a side effect, by the way, of SSRIs, but I've seen prescribed for that. For the loss of a dog, a pet dog. When a fellow lost his pet dog, first thing they did is say, how about an antidepressant? I was on a speaking tour 2 years ago. I'm going to reveal this. And it was not an organized tour. I was invited, like I've been invited here, to speak at various places. And there was a 2-month period. And during that 2-month period, I gave 14 talks in 6 different countries. And halfway through, at that time I was living in England, halfway through I was back in England and feeling really stressed out by this schedule. And I was seeing a physician for another matter entirely. And I told him the story. I said, you know, I'm halfway through, and I've got this many more talks to give, and I'm still going to be going. And he said, boy, that really sounds stressful. You shouldn't take on that much. But in the meantime, how about a prescription of citalopram? An SSRI. He didn't know my research.
You know, I have the opposite experience of what you're talking about, that when people realize that they're not helpless. You know, helplessness is a really difficult feeling for people. And if somebody tells them, oh, well, you know, it's just something going on with your brain, or it's inherited and there's nothing you can do about it, you have to take this pill, they feel very helpless. But when they understand that there's things they can do, that they can learn how to take loving care of themselves, that they can eat better, that they can exercise, instead of feeling judged, I see them over and over again feel relief. They feel hope. And that's what happens with the people. Even in one session, when I help them to start to look at what they're actually doing that they didn't realize. It's not that they're bad or wrong or that they need to be judged for what they're doing. They're doing the best they could. They're doing what they learned to do. You know, if you look back at what their parents did, they're doing what their parents did. And so it's not that they need to be blamed for anything, but when they realize that there is something they can do. And then I say, well, how do you feel now? And they always say to me, oh, I feel so much relief. I feel so much hope for the first time. People don't like to feel helpless over themselves. And so when they realize there's something they can do, they feel empowered rather than helpless.
Let's assume someone hears this and they say, okay, so it turns out that antidepressants are really no more than the placebo effect. There's no big deal. But they seem to be okay. I might as well stay in them anyways because maybe they know better than a placebo. But what's the big deal if you stay in antidepressants for 4 or 5 years? Like, what's the big deal?
Sure. You know, it's an active placebo, right? And we know placebos work. So let's give it to them as an active placebo, except for the health risks and the side effects. Do you know what the rate of sexual dysfunction is on SSRIs? 75 to 90%. I've seen 2 different estimates. The most recent one was over 90%. The one before that was 75%. Sometimes it goes away after 5 weeks of discontinuation. Sometimes it does not. That's just one of the side effects. Health risks for children and young adults can include the increase in the risk of suicidal behavior. In the elderly, there's an increased risk of stroke. There's an increased risk of death from all causes in the elderly with antidepressant use. There's an increased risk for everybody of type 2 diabetes. There's an increased risk of relapse, which we've talked about. And then there's withdrawal syndrome, and what you need to know it's not just the person taking the antidepressant that might experience the withdrawal syndrome. If that person happens to be a pregnant woman, especially in the latter stages of pregnancy, there's a 30% chance that her child will be born addicted to the SSRIs. That child will show what's called a neonatal abstinence syndrome. It's the same syndrome that is shown by the children, the babies, the neonates of mothers who are on heroin, barbiturates, cocaine.
Well, and I see other side effects as well. It's well known and documented in the literature that all drugs have a very negative effect on the gut flora. And so as you take the drugs, you are not only decimating your gut flora and creating toxicity, but you're creating the leaky gut syndrome, which creates even more toxicity and more illness. The other side effect that I see is that when we shove our feelings aside, which is what an antidepressant does, it pushes the feelings aside, like the grief. They're not going through it. They're not releasing it. They're shoving it down. When we shove feelings down inside, that in itself creates illness. A lot of illness is from people ignoring their feelings and not expressing them, not feeling them, not crying, not wailing, not really releasing them out of the body. When you learn to move towards your feelings, to embrace them, and allow them to release out of your body, then they don't get stuck inside. Stuck feelings cause illness. And so, you know, as I said in my other talk, many of you know that 90% of illness is stress-related. Well, when you know, the antidepressant is supposed to help take away the stress, but when you put a lid on feelings in any way, rather than with a medication or because you're in your head and you're ignoring them, you create stress in the body, physical stress in the body, and that creates more illness. So for me, it's so important with the people I work with to help them find a way to embrace and learn from their feelings and release them, rather than shove them aside with especially any form of medication.
Curious, this is just actually maybe a piece of trivia, but I can't resist it now, because you know, when a chemical like serotonin, for it to work, for it to do what it's supposed to do, it binds to what's called a receptor. Do you know where most of the serotonin receptors are? The gut. They're not in the brain, they're in the gut. That's where the largest concentration of serotonin receptors are. So that sparked that.
Yeah, and you know, so much of the research that's been going on is about the gut and is about what we need to do to heal the gut, because like I was talking with Brian Clement yesterday before he gave his talk on autism, and there's so much research on the fact that it's the problems in the gut that are creating the tendency towards autism. And then if the child lacks a good balance in their gut, and then they get vaccinations on top of it, that can trigger. And that's why some kids get it and some don't from the vaccinations, because some kids have healthy guts and some kids don't. And I don't know if many of you know, but when a child is born, they don't have any bioflora in their gut. And so the first dose they get is in the birth canal. But if they're born in C-section, they don't get any. And the second is in nursing. But if they're not nursed, if they're not breastfed, they don't get any. And so many babies are born C-section, or they're not nursed, or they're not nursed, or if their mothers are not healthy, then they're not getting healthy flora. And so these babies come in without healthy flora, and then, you know, they're getting ear infections, then they're getting antibiotics, and then they get a vaccination, and bam, they go into autism. But it's not the vaccination itself. It's that they're already sick. And they may be sick because their parents are taking medication like antidepressants and other medication that has destroyed their gut flora. And then it's being passed on. And so, from my point of view, I mean, unless it's a life-threatening situation, I personally, I don't take medication. And so unless it's a life-threatening situation, I'm going to find some other way of dealing with something other than medication.
And I just have to make it clear that I'm not against medication in general. And I do take medications. I'm against medications that are ineffective and carry risks without the benefit.
Right.
You always have to look at the risk-benefit ratio, and apropos of what you were saying, Margaret, one of the other risks of antidepressants, of SSRIs in particular, is that it increases the risk of autism when taken by a pregnant woman. It also increases the risk of physical deformities in the baby, and that's even if it's taken in the first trimester, when often the woman might not even know, before the woman even knows that she is pregnant.
The audience here today knows very well that when they go in the supermarket, it doesn't matter which one of the sugary cereals are on the aisle, they probably don't trust any of them. They go in the candy aisle, it doesn't really matter the brand, they don't trust any of them. They go in the soda aisle, the chips aisle, they don't trust any of them. But when it comes to prescription drugs, they trust very much. They believe, and so I do, that doctors are incredibly smart people, and we believe they're very honest, and we have very good feelings. And they prescribe not only antidepressants, but a whole bunch of other ones. Now, is this an isolated thing, the placebo effect with antidepressants, or could anything be extrapolated from this to say that if the number 1 or 2 biggest drug in the world, antidepressants, turns out to be similar to a placebo, does that mean anything about all these other ones that we're trusting very comfortably that the doctor is an expert in and it must be effective, or is it possible that other drugs also are like this?
There are some other drugs that have large placebo effects. There are many drugs that do not show large placebo effects, so you can't overgeneralize. We know that antibiotics can help heal infections. Placebos do not. Placebos do not have an effect on blood sugar levels. They don't heal fractured bones. They have a tremendous effect in mood disorders, including depression and anxiety. They have a fairly substantial effect on pain. About half the effect of a pain reliever is a placebo effect. And that is true for aspirin, and it's true for non-steroidal anti-inflammatories, and it's true for morphine. And you say, well, how can that be? I mean, morphine's more effective than ibuprofen. So if morphine is twice as effective as a placebo, the placebo must be more than half as effective as the ibuprofen. Is that making sense? And here's the key. There isn't one placebo effect. There are many placebo effects. And how strong the placebo effect depends on how strong you think the drug is that you're taking. So placebo morphine is more effective than placebo ibuprofen by a fair degree.
But I think you're also asking, Stephen, about drugs like statin drugs for cholesterol and things like that. And I think there's a lot of research out. I don't have this, the research at my fingertips, but I do a lot of reading. And I see that there's a lot of research out about what these drugs actually do and how harmful so many of them are on many, many levels. So I want to suggest that nobody just accept what their doctor says. Just because this doctor is trained in what they do doesn't mean that they're trained in preventative health in any way, doesn't mean that they're trained in understanding. They're treating the symptom. They're not treating the underlying problem. And fortunately, there's functional medicine doctors that are getting the training that they need to deal with the underlying problem, so that they don't just give a drug for symptoms which ultimately can harm the person, but they're dealing with what's really going on within the body.
In your book, you said that if I understood this right, in Irving's book, you said that, I think I got this right, that 40% of all depression trials were never published. Did I understand that right? And why would that be?
You're absolutely correct about that. Here's what happens. If you look at the published trials, 60% of the trials are published, you find that 3 out of 4 of them show a small but statistically significant difference between drug and placebo. 40% are not published, and if you look at them, you know why immediately. Hardly any of them. So I can tell you the exact percentage. 12% of them show a small significant difference between drug and placebo. 88% of them do not show any statistical effect of the drug over placebo. The pharmaceutical companies are not going to want to publish data that shows that their drug is ineffective, and they avoid doing so. And that means that researchers have a hard time knowing what the drug is really doing, and it means that your doctor's going to have a hard time knowing how effective the drug really is, because the data aren't available. That's why we went to the FDA and used the Freedom of Information Act to get the data that had not been published. There is one pharmaceutical company that makes an antidepressant, it's GlaxoSmithKline, that does publish online the results of all clinical trials. Now, you might want to applaud them for that until you find out why it is they do that. It's not out of the goodness of their heart. They were sued by the state of New York for hiding the data on how ineffective paroxetine is, it's an SSRI, for children and adolescents. And in settling the lawsuit, they agreed, and so they are now legally bound to make this data available online. They still don't publish it when they don't have something they want to publicize well, and they're the only drug company that has to do this, to my knowledge, at this point.
Margaret, without going into all the details of the inner bonding process, if you were going to, in a quick way, just try to sum up from all your years, what does it take for a person to feel the opposite of depressed? Full, loving, happy, peaceful? What should someone do if they want to have a very full, happy, fulfilled life? What do you do? How do you do that?
Well, the first thing that you need to be willing to do is to feel your feelings rather than avoid them. Until you're willing to feel your feelings and learn from them, you're going to turn to various addictions and other ways of avoiding them, and so that's going to make you depressed. Any avoidance of feelings can lead to depression. And so you need to be willing to reverse what you've been doing and embrace, with a deep intention, to learn about what your feelings are telling you. You need to learn to be present in your body. You know, this takes practice. This is a mindfulness practice where you're moving out of head focus, mind focus, and into body focus so that you become aware of what you feel. If you're not aware, then how do you know when to turn towards your feelings and when to embrace these feelings? And so it takes some practice. And the other thing is that's vitally important is to develop a two-way relationship with a higher source of guidance. And it can be whatever it is for you. It can be your higher self, it can be God, it can be just spirit or light or inner wisdom. It doesn't matter what it is for you. But it has to be beyond your limited mind, because the mind is so programmed. The ego-wounded mind is programmed with so many fears and false beliefs. And we have to get beyond that into a source of truth and into a source of love. Because ultimately, what heals is love. And love is the great healer. And so we need to be able to tune into, there's a source here. It's infinite. It's vast. And all of us can learn to tune into that source of love and of truth. And as we learn to tune into that, and we bring that down inside to our feelings, That's when we start to heal. There's a lot of people who are on a spiritual path, and they will tune into that love, and they'll bring it into their heart, and then they'll send it right out to other people. Now imagine that your feeling self is like a child inside. And instead of bringing that love down inside to that child in you first, and then sending it out, you're bringing it and sending it out to everybody else, and this child is left alone and abandoned. And then what that child does is try to get everybody else to love him or her. So we have to learn to tap into that source, bring it into our heart, bring it down inside to our feelings, learn what our feelings are telling us, learn what would be the truth and what's loving to us, and then take that loving action in our own behalf. And that's really what the inner bonding process is all about. 6 steps that bring you through that, so that with practice, you start to do that naturally in your life. And as you practice it, you're developing new neural pathways in your upper brain and your higher brain, because back here are the neural pathways for the ego woundedness. And that's what we habitually do. And so as you practice this, you develop the neural pathways, and then it becomes easier and easier to take loving care of yourself. And that's what heals depression, as well as anxiety and guilt and shame and anger and emptiness and aloneness, all of these feelings that people suffer from so much. And as you learn to do this, then you learn to manage the very painful feelings of life, the loneliness, the heartbreak, the grief, the helplessness over people and events. You learn to manage them with love, so that you don't need to keep avoiding them with medication or addictions or staying in your head or judging yourself or making others responsible. When you learn to manage your feelings, that's when you have a lot of peace and joy in your life.
I listened to you, both of you, talking about the psychiatric medication, and I agree with you that some of the people are over-medicated and they shouldn't be on drugs anyway, but I take care of psychiatric patients, and I'm telling you, without their meds, they punch me, they beat me up, they do all manner of evil to me. So how would you recommend that somebody who's been on long-term psychiatric medication like 10, 15, 20 years, what would you tell them about getting off their meds? Because without their meds, they're not even functioning. And I agree that there's so many side effects. I would like to take them off. But without their meds, they can't even function, and they're dangerous, really dangerous. So how would you help?
Well, I think that, in some situations, if a person is dangerous and if the medication is helping that's appropriate. But I also think that person needs to be in treatment and to be learning how to be loving to themselves. If they're dangerous, it means that they are completely out of touch with who they really are. And so, I wouldn't just get them off medication, but I have certainly worked with people who are very rageful and can hurt people. But as they practice inner bonding and they learn to tap into their guidance, they learn to get into their heart, they learn what happened to them in the past that was so painful that they completely disconnected from the beauty of who they are. As they learn to do that, and then they start to get better. I don't know if you've ever seen the movie Dead Man Walking with Susan Sarandon. Okay, so here was a very dangerous criminal. And she was a great role model for being a loving adult. She did not coddle this guy. She did not accept what he did. But she brought him so much love. And she helped him discover who he really was inside. And in the end, before he died, he was redeemed. He was able to apologize. He was able to feel the sadness of what he had done. That's what it takes. It takes that kind of treatment before somebody can go off that level of medication.
Well, I don't think you're talking about antidepressants in particular from the way you describe the treatment facility and the patients that you've been seeing. So I would limit my comments, again, for the reasons that I've explained before, to antidepressants. It is true that you have people who have been on long-term antidepressants, and if you take them off it, they're going to show a very bad reaction for two reasons. Immediately, because they go through withdrawal syndrome, and later relapse, because you have done something to their brain, and they are now more susceptible to relapse. With respect to antipsychotics, I would recommend that you come to one of the sessions in which Mr. Whitaker is speaking, who wrote the book Anatomy of an Epidemic, and does address antipsychotic. Robert Whitaker does address antipsychotic medication. I've read two of his books. I found them excellent. I wrote a book review for one of them, and I recommend listening and reading his books to you very highly.
Hi, my question is a little bit about the gut diet that you were talking about. I guess can you walk me through like a day of what you would eat as part of the gut diet, what foods you would recommend to eat and what foods you would recommend to stay away from specifically?
Well, I don't like to recommend specific diets, because what I do recommend is for people to stay tuned into their own body, because everybody's body is different and everybody is going to need something different. But as far as the gut flora goes, there are general recommendations. One is eat organic, eat clean, eat as local as you can, and get as much probiotic foods into you as you can. Sauerkraut, kimchi, kombucha, water kefir, as many probiotics as you can find to put in your body. You might want to do some research as to what does contain probiotics. And so it's up to each individual to find the kind of diet. I mean, there is not just one that works for everybody. And so that's part of tuning into oneself, what feels good and what doesn't feel good in your body. But everybody needs to look into the fermented foods.
Thank you.
Mm-hmm.
Thank you for what you do. A couple of things I'd like you to explain or expand upon. The link, I forget who mentioned that they did not feel there was a link between serotonin and depression, though I do believe that there's evidence that there's a link between serotonin and anxiety. And I believe that Dr. Daniel Ammon said that women in particular have about 60% less serotonin in their gut than men. And the second thing I'd like you to comment on is, what is your opinion on HTP and maybe other supplements to increase serotonin levels, or even targeted amino acid therapy?
I will address the first of those questions and pass on the second, because my knowledge base is not, haven't seen the data well enough to be able to confidently make a statement on that. I will talk about the issue of serotonin. And remember, the serotonin hypothesis for depression is not linked to the gut, it's linked to the brain. Now, I have looked at and studied and published on the effect of SSRIs on anxiety disorders in comparison to placebo. And I can tell you that they are no better than SSRIs for depression. It has no better effect. The placebo effect is most of what you're getting, whether it's a depressive disorder or an anxiety disorder. I've looked at it. There's another group who published it last year. There's another group of researchers in Canada who looked at it and published it. I believe it was this year when it came out. They found the exact same thing that we found. Let's talk about the drug research on serotonin and depression for a minute. There's a drug called tianeptine. Have you ever heard of tianeptine? Tianeptine is approved as an antidepressant in France by French regulators. It's prescribed in a number of companies. Manufacturers have not applied for approval in the U.S. By the FDA. Tianeptine is an SSRI. SSRI stands for Selective Serotonin Reuptake Inhibitor. Tianeptine is a selective serotonin reuptake enhancer. It's supposed to do exactly the opposite in the brain of what SSRIs are supposed to do. Instead of increasing the amount of serotonin in the brain, it's supposed to decrease the amount of serotonin in the brain. So if SSRIs are curing depression by increasing serotonin, tianeptine ought to make people worse. The response rate in depression for tianeptine is exactly the same as it is for SSRIs. It doesn't matter whether the drug you give somebody increases serotonin, decreases serotonin. It's not supposed to have any effect on serotonin. In a double-blind clinical trial, if it has side effects so they can figure out what it's going to give you a small benefit over inner placebo. They look at response rates, which is how many people get better enough to say they have responded. The response rate to every single antidepressant, including tianeptine, is about 60%.
But, let me address the whole issue of the gut flora, because that's where most of the serotonin is. And if you look at the research, you will find that dealing with what you put in your body, or what you don't put in your body that is ruining the gut flora, that's what can help the anxiety and the depression, because the serotonin level goes down when there's gut dysbiosis, which means that the wall is opening up. And as you learn to heal the gut and bring in the probiotics, the prebiotics, that gets healed, and that greatly affects anxiety and depression.
Yes, I'm familiar with the gut-brain connection,
Yeah.
and dairy I know is a big, and casein as a culprit. What are your thoughts on HTP?
I don't know much about it, so I can't really comment on it.
Okay, thank you very much. Thank you.
Okay, I want to thank Margaret Paul and Irving Kirsch for this wonderful panel.
Thank you.
And